let's move on to the evolving role of HER2-targeted therapy. And maybe just give us a little bit of history about trastuzumab and pertuzumab in the combination.
Yeah. So obviously, like you alluded to earlier, we've had trastuzumab since the 1990s, and we all know, honestly, it's one of those career-altering, life-altering discoveries, the work of Dr. Slayman, and it was definitely a flashbulb moment in the field of oncology when we had trastuzumab. But we started to see it used in combination with pertuzumab through the work of the Cleopatra investigators. And in those studies, they combined pertuzumab, understanding that because pertuzumab works by inhibiting receptor dimerization, that it would be complementary to trastuzumab for patients with HER2-positive metastatic breast cancer. And in the Cleopatra studies, we ultimately saw an overall survival advantage for patients that got the dual HER2-targeted therapy of trastuzumab and pertuzumab that was also dramatic in a way that was exciting. We saw that median overall survival improved from 40 months to 56 months with a hazard ratio of 0.68. And so that paper was practice changing, and we now consider taxane-based dual HER2-targeted therapy to be the standard of care in the upfront management of metastatic HER2-positive breast cancer. And that really has set the pace for HER2 drug development. And since the Cleopatra study and pertuzumab has entered the stage, we've had all of these new drugs that are starting to emerge, and that is really exciting. So do you want to tell us a little bit about the TDM1 story? Because that was just right at the same time and on the heels of the pertuzumab story.
Yeah, absolutely. TDM1 is an antibody drug conjugate, and I kind of go through this silly spiel with my patients to explain exactly what an antibody drug conjugate is. Is it chemo? Is it not chemo? Exactly what is it? And so an antibody drug conjugate is really where you have the chemotherapy that's attached to the antibody. And so I explain it as when we infuse that compound into the body, it kind of just floats around, not really doing much. It's not like a naked chemotherapy. It's not going to attack all the cells at sea. Instead, when the antibody binds the target cell, in this case, if it's trastuzumab, it's the HER2 receptor, then that's where the chemo is released directly on the cell. And so it got coined in the media really as being a smart bomb, right? It's a targeted way to deliver chemotherapy directly to the cell that you're trying to get at. And so TDM1 is a beautiful example of this. It's chemotherapy that is linked to the trastuzumab molecule and gets that molecule exactly where it needs to go to combat cancer. And so, TDM1, as many drugs in breast cancer and oncology, was really first thoroughly explored in the metastatic setting. It's kind of settled in as our second line treatment of choice after taxane, trastuzumab, pertuzumab. We often use TDM1. TDM1 has some advantages. I find that my patients feel pretty well on TDM1. They don't get as much neuropathy, hair loss as naked taxane, as I call it. We do have to watch low platelets and elevated liver function tests in patients. But again, for the large part, those are laboratory abnormalities that we can kind of watch and adjust dosing as needed. There is some cumulative fatigue that I think a lot of patients experience with TDM1 as well. But I've certainly had patients that do very well on TDM1 and can tolerate it for a number of years. Stephanie, what's been your experience with TDM1?
Yeah, I think that compared to trastuzumab, pertuzumab in combination, I've seen more diarrhea that can be limiting for some patients. Although, again, on the dual HER2 blockade, patients do great and have a great side effect profile, toxicity profile. With TDM1, I agree, mild platelet, LFT, abnormalities that for the most part are lab changes that don't necessarily have a clinical implication for the patient. However, I have had a few patients whose peripheral neuropathy continues to progress or amplify on TDM1, so it's definitely something I continue to monitor for those patients.